Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Treponema pallidum or syphilis under the section of infectious diseases. So this is a picture of a slide of Treponema pallidum or syphilis, which is probably worth to have a rough idea about. In terms of its epidemiology, it has a higher prevalence in the developing countries. The high-risk populations include men who have sex with men, those who have multiple sexual partners, and it could also be transmitted through mother to baby through the placenta. And resurgence has been happening in many countries, in fact, over the past decade. The pathophysiology of syphilis is that it is a spirochete bacterium and it invades through mucous membranes or skin abrasions. And this is then followed by systematic spread through bloodstream. The clinical manifestation can be divided into primary, secondary, latent, and tertiary syphilis. The primary syphilis, it normally starts with a chancre, which is a single, firm, round, painless ulcer at the site of the infection. And this is followed by regional lymphadenopathy, which importantly is non-tender on palpation. And the duration of this is normally anywhere between 3 to 6 weeks. The secondary syphilis is then when you have mucosal involvement, and that includes classically involvement of the palms and soles, resulting in a diffuse maculopapular rash. You can also have involvement of the mucosal membranes, and this is when you get your systemic involvement, including fever, malaise, and lymphadenopathy. The duration of this is also around 3 to 6 weeks. Then you will have latent syphilis, which can then itself be divided into two categories. One of them is an early latent, which is within the first year of the infection, and the other one is late latent, which is after the first year. And normally the patients are asymptomatic in this scenario. However, they are seroreactive. And finally, the last stage, which is your tertiary syphilis, which is when the disease affects various systems and organs in the body. And this includes affecting cardiovascular systems, resulting in aneurysms and aortitis, affecting the skin, bones, and liver through production of gumas or gummatous lesions. It could affect the central nervous system, in which case it's called neurosyphilis, and it could cause general paresis and tabes dorsalis, and also impairment of the cognition and motor function. The duration of this is normally very long, and you're talking about anywhere between years to decades after the initial infection. On the right-hand side, you will see quite a nice diagram that talks about the progression of syphilis. So you have your chancre, which is a painless lymphadenopathy on the lateral aspect of the neck, and then it can result to gummatous lesions in the case of tertiary syphilis. So the diagnosis is really through serological testing, and that includes tests for treponemal and non-treponemal species. The tests for treponemal species will include your FTA-ABS, which is your fluorescent treponemal antibody absorption, and TPPA, which is T. Pallidum particle agglutination. And the test specific for non-treponemal species will include the RPR test, which is the rapid plasma reagent test, and the VDRL test, which many of you are familiar with, which is the venereal disease research laboratory test. Then you have your direct detection method, and that includes dark field microscopy, which is direct visualization of the spirochetes from the lesion exudate. And you have your PCR method, which is a detection of the Treponema Pallidum DNA. And finally, you have the CSF analysis, especially useful in the case of neurosyphilis, in which case you will find elevated protein, pleocytosis, and positive VDRL in the CSF sample. In terms of the management of syphilis, the first-line treatment is with benzathine penicillin G, and approximately, to just give you an estimate, it is used in 2.4 million cases as a single IM shot globally. Alternatively, especially for those patients who are allergic to penicillin, you could use doxycycline 10 mg orally twice a day for a duration of 14 days. It is worth noting that you do need to be repeating the non-treponemal test, which includes the PRP or the VDRL test at 6, 12, and 24 months post-treatment to make sure that it is completely treated and the treatment is satisfactory. And regular clinical evaluation to assess resolution of symptoms and identify any potential latent complication of the disease is also strongly recommended. You, of course, do need to notify the sexual partners of the patient, and you do need to be teaching and encouraging safe sex practices. And it's strongly recommended that you do involve the multidisciplinary team in this, including the involvement of your infectious diseases as well as genitourinary medicine colleagues for optimal management and care. Let's do some questions. Question 1 is a 34-year-old woman presents with a diffuse maculopapular rash, including on her palms and soles, along with generalized lymphadenopathy and flu-like symptoms. Which stage of syphilis is most likely based on her presentation? So this is giving you a diagnosis already that this is syphilis, but they're asking you to categorize what stage she is exactly at. A, primary syphilis, B, secondary syphilis, C, latent syphilis, D, tertiary syphilis, E, congenital syphilis. And with just a quick look, you will realize that option A is completely incorrect because she's 34, so she's not going to have congenital syphilis. Option A, if you remember, is when you have your painless chancre, so that's not going to be right. And option C is the latent syphilis, which is, if you recall, is happening within the first year, depending if you're talking about early latent or late latent, but you're talking about nearly, a few months to more than a year, possibly. So that's not going to be correct. And then option D, which is a tertiary syphilis, is also not going to be correct because recall that tertiary syphilis, you do expect many years to decades to pass from the initial infection. And more importantly, classically, the way that they are describing the scenario to you with the presentation of the diffuse maculopapular rash affecting the palms and the soles and generalized lymphadenopathy is really quite classic for secondary syphilis, which you have the mucosal involvement and you have that non-specific constitutional symptoms such as fever, malaise, and lymphadenopathy. Therefore, the correct option is going to be option B for secondary syphilis. Thanks for listening to this episode of Bite-Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.